So now, to proceed with, I'm passing the control to Dr. Uzair Ghani, who will formally start this webinar. Over to Dr. Sir.
We are going to be very open and frank. So this is going to be bilingual. Feel free to ask question in either Urdu or English. तो और आपको मुबारकबाद देता हूँ अल्हम्दुलिल्लाह कि अब पाकिस्तान में 4 कोविड की वैक्सीन को इजाज़त मिल चुकी है और इंशाअल्लाह ताला बहुत जल्द तमाम लोगों को वो अवेलेबल भी हो जाएंगी फिजिक मैनर में। सबसे पहले मैं तारुफ कराना चाहूँगा आज के मॉडरेटर्स का और जो क्वेश्चन आंसर सेशन को लीड करेंगे डॉक्टर हामिद मर्चेंट, डॉक्टर शुमाइल दाऊद जो कि यहाँ मौजूद हैं, ये मॉडरेट करेंगे। डॉक्टर शुमाइल का जो बैकग्राउंड है हेल्थ केयर सिस्टम से और पब्लिक हेल्थ से है, ही इज़ क्वाइट अ नोन स्पीकर और बहुत दफ़ा आपने उन्हें मीडिया पे भी देखा होगा, मुख्तलिफ चैनल्स पे भी देखा होगा। बाय क्वालिफिकेशन ही इज़ अ मेडिकल डॉक्टर और फर्दर इनकी जो क्वालिफिकेशन है दैट इज़ फ्रॉम यूके एंड यूएस। सो ही इज़ engage with the healthcare delivery system और public health की policy matters के ऊपर he is part of many groups, think tanks. तो बड़ा he is watching this vaccine development and evolution since its beginning and inception. तो he is engaged with all of these activities policy level पे भी, public education और health के level पे भी और all those sector और अपनी इनकी एक personal बहुत बड़ी following है patients की। is also running a group of hospitals as well. तो I welcome Dr. शुमाइल दाऊद। हमारे दूसरे स्पीकर डॉक्टर हामिद मर्चेंट हैं, he is from Huddersfield. I think for any good reason he is a very punctual person, but you know because of the weather condition maybe there is some delay, so but we will keep it on. मैं थोड़ी सी चीज़ें आपसे शेयर करना चाहूँगा कि ग्लोबली इस वक्त हो क्या रहा है बिफोर इसके कि हम फॉर्मली जो पिछले क्वेश्चन आंसर हैं और नए क्वेश्चन आंसर्स लें। तो इट इज़ जस्ट रिकैप ऑफ यस्टरडे एक्टिविटी। तो एज ऑफ यस्टरडे तकरीबन 11 ऐसी कोविड की वैक्सीन हैं जो कि ग्लोबली कम से कम एक मुल्क में उनको इजाज़त मिल गई है लोगों को लगाने के लिए। उसका स्प्लिट कुछ इस तरीके से है कि उसमें से 2 वैक्सीन रशिया से ताल्लुक़ रखती हैं जिसमें एक स्पुतनिक है जो बहुत जल्द पाकिस्तान में भी अवेलेबल होने वाली है और दूसरी एपीवैक कोरोना है। इसी तरीके से चाइना से 4 वैक्सीन्स हैं। 2 वैक्सीन साइनोफार्म की हैं जिसमें एक कॉमनली नोन वैक्सीन जो यूएई में भी लग चुकी है और अब पाकिस्तान में भी उसका गिफ्ट में 500,000 डोजेज और अनदर 500,000 डोजेज आ चुके हैं जो कि हेल्थ केयर के पर्सनल को लगाई जाएगी और उसके अलावा कुछ और स्पेशल एज सेगमेंट के लिए रिजर्व की गई है। तो 2 वैक्सीन साइनोफार्म से हैं लेकिन उनमें कॉमनली एक ज़्यादा यूज़ हो रही है जो बीजिंग बायोलॉजिकल प्रोडक्शन की है, दूसरी वुहान इंस्टीट्यूट की ट्रायल में यूज़ की गई है और चाइना में रिस्ट्रिक्टेड यूज़ है उसका लेकिन ओवरऑल अवेलेबल नहीं है। दूसरी जो वैक्सीन चाइना से है वो कैन साइनो बायो है। तो ये वो वैक्सीन है जिसके पाकिस्तान में ट्रायल हो चुके हैं, तकरीबन 17,300 और 400 लोगों पे इसके ट्रायल हुए और जिसके अच्छे रिजल्ट्स मिले हैं और इसको भी गवर्नमेंट ऑफ पाकिस्तान ने इजाज़त दे दी है और दिस इज़ गोइंग टू बी अवेलेबल वेरी सून। एक और वैक्सीन जो चाइना से है साइनोवैक के नाम से है, तो इसको भी कुछ ममालिक में इजाज़त मिल चुकी है। सो जस्ट टू रिकैप ऑल टुगेदर 4 वैक्सीन चाइना से अप्रूव हैं या कहीं ना कहीं यूज़ हो रही हैं जिनमें से 2 पाकिस्तान में आपको अवेलेबल हो जाएंगी, एक हो चुकी है और एक होने वाली है। اب ہمارے ہمسایہ ملک انڈیا کی طرف دیکھیں, وہاں سے 2 ویکسین جو ہیں وہ مین اسٹریم میں ہیں اور ان کا تعلق وہاں سے ہے. ایک ایسٹرا زینیکا کی ویکسین ہے جو سیرم انسٹیٹیوٹ آف انڈیا میں بنائی جا رہی ہے کووی شیلڈ کے نام سے, اور کوویکس اسکیم کے تحت دنیا میں اویلیبل ہوگی. اسی کا ایک ورژن جو ہے جو ایسٹرا زینیکا کا مین یو کے میں بھی اویلیبل ہے, مین کمپنی وہاں پہ ہے. تو دوسری انڈیا کی جو ویکسین ہے وہ کو ویکسین کے نام سے ہے جو بھارت بایو ٹیک کی ہے, تو یہ بھی وہاں سے ہے. جسٹ ٹو گیو یو فگر, ابھی تک ٹل یسٹرڈے 338 کروڑ ویلیو کی ویکسین انڈیا ایکسپورٹ کر چکا ہے. اس کے علاوہ یو ایس جہاں پہ مین کمپنیز 2 فور فرنٹ پہ ہیں, ایک فائزر موڈرنا ہے, اور ایک فائزر بایون ٹیک ہے اور دوسری موڈرنا ہے. 2 ویکسین کیو میں ہے ٹو بی اپروڈ جانسن اینڈ جانسن کی اینڈ نوو ویکس کی. تو اب ہم آتے ہیں پاکستان کی طرف. جیسا کہ آپ کو پتہ ہے کہ پاکستان میں اس وقت 4 ویکسین کو کسی نہ کسی شکل میں اجازت مل چکی ہے. میں دہرا دیتا ہوں. نمبر 1 سائنو فارم جو کہ چائنا سے ہے, ان ایکٹیویٹڈ ویکسین ہے, باقی حامد اس کے بارے میں زیادہ روشنی ڈالیں گے. دوسری کوویکس کا حصہ ہے جو ایسٹرا زینیکا کی ہے. اس کے بعد رشین جو ہے سپوٹنک, اس کو بھی اجازت مل چکی ہے. اور لاسٹ ون جس کو ملی ہے وہ کین سائنو بایو کی ویکسین ہے. تو ٹل یسٹرڈے دنیا میں 168 ملین ڈوزز لگ چکے ہیں کووڈ ویکسین کے, اور 77 کنٹریز میں ایکٹیو ویکسینیشن ہو رہی ہے, اور ڈیلی 5.84 ملین ڈوزز لگائے جا رہے ہیں. سو دیٹ واز اے کوئک دی گراؤنڈ سینیریو, وہ میں آپ سے شیئر کرنا چاہ رہا تھا. میں چونکہ کوئکلی پاس آن کرنا چاہوں گا ٹائم سیو کرنے کے لیے. ڈاکٹر حامد مرچنٹ آ چکے ہیں اور اب میں ان کو ویلکم کرتا ہوں اور ان کو انوائٹ کروں گا کہ وہ اب کنٹینیو کریں جو کویسچن آنسر سیشن ہم نے سٹارٹ کیا تھا. تو تھینک یو ویری مچ حامد فار جوائننگ, اینڈ اٹ از اوور ٹو یو پلیز.
Thank you very much for the invitation, and apologies for the delay in just connecting it up. I'm happy to answer any questions which the audience have.
Thank you very much, Hamid. Dr. Uzair has already introduced me and given me the responsibility to moderate and ask the questions. So I will share the questions that have been put forth in your last very informative session. So I'll just go, they're not in a particular order, but one of the questions was, what if somebody produces antibodies against the adenovirus, because we do know that some of the ones that you mentioned, unke andar adenovirus use hota hai.
That's a very important question. इसमें दो पहलू हैं इसके जवाब देने में. One is the pre-existing antibodies against adenovirus, and the second aspect of the question is the antibodies produced as a result of vaccination. So if you look at some of the phase 1 and 2 data from some of the vaccination trials, particularly the one from CanSino Bio, Oxford University, and the Russian Sputnik one, which have used the viral vector vaccine, you can see the trial participants, when they look at the small subgroup of the trial analysis, the trial participants all had pre-existing antibodies against adenovirus. Now that's the first thing to start with, the baseline antibody levels. So when I looked at the data, half of the trial subjects had lower level of antibodies against the adenoviral vector. The remaining half had a higher level of pre-existing antibodies against the viral vector. And that translated into the efficacy later. So not really the efficacy, but the immunogenic response, if you like. There's no direct correlation and evidence so far with the efficacy, but we can apply the science to explain that. So if you look at the immunogenic response, then the subjects which had lower level of pre-existing adenoviral antibodies or immunity, they produce much more higher titers of antibodies against the coronavirus. So the viral vector was not attacked as much as in the other subjects with a higher level of pre-existing immunity. Now, what AstraZeneca did was to avoid that factor. They used a chimp-based adenoviral vector, which human population was not pre-exposed to. So chances was that the pre-existing antibody would not exist when these vaccines would be given, like Oxford University AstraZeneca vaccine. So you would expect, a much more kind of enhanced immune response against the coronavirus. Now, the second aspect is during vaccination. So most of the vaccines were trialed for 2 doses. So what happens is once you administer the vaccine, so you have one pre-existing antibodies against the human adenoviral vector or no pre-existing antibody against the chimp vector. But once the first dose goes in, then your immune system starts to learn the vector as well, as far as it's produce antibodies against coronavirus, but it also learns the vector, and the vector is also a virus. So immune system memorizes that virus. It cannot react immediately because it's the first dose. It wasn't aware of that before, or maybe pre-existing immunity was lower in those individuals. But by the time you bring in the second dose, now body is very clever. It has understood the viral vector, and then it attacks the viral vector himself. So in a way, body produces antibodies against the vaccine, and vaccine second dose doesn't work as good as the first dose works. This was one of the reasons why AstraZeneca had a bit of a trouble in their efficacy trials later on, and their trial was then reinitiated to look at lower dose, maybe priming it with the first dose and then using a second dose with a booster level. And they were trying to see how we can best manipulate the immune response. And more recently, they've also thought about the way the Russian did it. So in Russian vaccine, in the Sputnik, you have 2 doses, and both dosages are not from the same vaccine formulation. They have 2 different formulations. The first one is AD26, which is the adenoviral vector. The second one is your AD5. And now Oxford University has also decided to use one of their first vaccine and then AD26 as a second dose of Russian vaccine. And they are trying to also mix and match these 2 different vectors and see if they can improve the efficacy against the vaccine. So it's a very important question that the body does produce antibodies against the adenoviral vector, and the human adenoviral vector AD5 and AD26, majority of us have been already pre-exposed. It depends depending on geographical region what the prevalence of adenovirus are and how much the core virus spreads around in those regions. So the level of those baseline antibodies would differ in people. So the response from community would not be similar. There will be a huge variability in people responding to vaccine.
Right, thank you so much. So on the same line, somebody had asked, do we really need a second dose if somebody was infected? Let's say if the similar viral vector vaccine is the one, do we need a second dose if somebody was infected in the past, or they could skip the second dose?
A very good question, and that's been very important in determining public health campaigns as well, and the vaccine immunization campaigns. There is no direct evidence so far because we have not done any clinical trials in respect of working out seroprevalence of recovered patients from COVID. It's been a bit disappointing that even in the United Kingdom, the way we have spread out testing, we are testing hundreds of thousands of tests every week on daily basis as well. So we have really spread out the mass testing, but we are only relying on antigen screening program. We have not gone into seroconversion, in the community. So it's a very important question because we have a lack of supply of vaccination as well. So we haven't got enough number of doses for everybody. So when the herd immunity was modeled by the modeling scientists, they were also looking at people who are already exposed to the virus or recovered from the virus as people who have achieved in the immunity targets. So to make sure that that model works with all those predictions, we would have to prioritize vaccination in those individuals who have never got the disease first, who have never been exposed to the virus, so we can have a cumulative higher proportion of public within herd immunity. So this question relates to that question saying, what if I've got the virus? Should I take the vaccine or not? Normally, the data we have available so far in seroprevalence studies in small communities and populations, we have seen that antibody titers in the recovered peoples are lower. In majority of people, they haven't got enough antibody titer. So if you go for a personalized approach, let's saying person X would need it or not, we need to look at their titers. And in a public health scenario, it would be difficult to then pre-test everybody with their antibody levels to decide about vaccination. Second thing was that when vaccines were designed in phase 1 and 2 trials, the goals and the bars were set at least 10 times higher or 100 times higher the antibody levels as you would find in the recovered patients. So the bar was very, very high. So vaccine produced antibodies are a lot more higher in quantity and titer compared to the naturally acquired immunity or antibodies, which is why a vaccine would still be beneficial to boost your response. Now, if you recovered from the virus, the chances are that you would have got some antibodies if you were lucky, and some immediate antibodies would have been neutralized, and then IgG would have been lasted a bit longer. Then your T cell response, your memory function is there, your body remembers the virus. So when you get the first dose of the vaccine, it would work like as a second dose in you, because your body already been exposed to the virus. So the response, immune response with the first dose in your body would be very similar to the second dose in somebody who never had a virus exposure. So you will boost up in one vaccination. So in public health point of view, I would spare the second dose in those people and would not give it there, and rather put it to other people where I'm struggling with the first vaccination.
So let me just interject here, and that's going to just, I think, make it easier for everyone to understand. One of the questions was that if somebody has had a severe spell of the COVID, then how he would, I mean, on the same accord, if somebody had a light spell, maybe asymptomatic or light, attack of COVID and has recovered, and how do we look at somebody who had a severe attack and was even hospitalized or was a bit severe? How would we look at it on the same accord? So carry on.
Yeah, thank you very much for bringing this bit in, because normally what happened with immunology is your body is very clever, and body does not always waste its precious resources in just producing antibodies for everything it encounters. So there are different levels of defense in the body. The first level of defense is like in a country. You think about your own country, you have a border security force protecting your border. So if an enemy attacks at your border, the first response your country's army would do is at the border, try to defuse the situation at the border. You wouldn't wait until the army comes in the cities and start destruction. Mm-hmm. But if you couldn't stop all of it at the border, if the attack was very severe, if the attack was from multiple sides, and if your body's resources could not be able to neutralize the heavy load of the attack, then some will skip through into the cities, and then you would have to also initiate your defense systems or kind of response attack within the country or within the cities. Same things happen in this immunology. So when the virus goes in through your nose, through your mouth, the mucosal antibodies, the mucosal immune system response is the first response which body produce, and body try to diffuse it out. You had a T cell response, you have a phagocytosis, you've got all those kind of processes kicks in. Many people never produce IgGs. So if the virus did not make its way to the blood circulation, it has never affected liver, never affected other systemic organs, you wouldn't expect that person would produce IgGs, which is why lots of people recovered from COVID would not even test positive for antibodies. Mm-hmm. Mm-hmm. So IgM level sometimes kicks in, but then they go down when the person recovers, and sometimes IgG levels doesn't, escalate. So there is a very important correlation between disease severity and antibody levels. So the more your body feels the danger, the more damage is virus doing in your body. If you get to hospitalized state, if you went to the ICU, you are likely to produce higher response of antibodies in your blood. So going back to the previous question, so definitely if you have recovered from the COVID, if you're a healthy individual and you successfully defended it without heavy interventions, your first vaccine dose would be good enough for several months. And instead of taking the second dose very quickly for the same vaccine, you might wait and see if there's a new vaccine formulation coming in which could provide a broader coverage against a new variant, like a flu vaccine. There might be a possibility of having a frequent immunization program every winter or just before winter. And then that might be more logical for those individuals. Plus, you will also spare the second dose for those people in the community who haven't got any vaccine yet, because we haven't got plenty of quantities. If we had plenty of quantities, we would have said, yeah, everybody get two, no harm in it, But because of public health side as well, looking at the science, looking at the medicine, but also looking at the public good overall, I think the decision making has to be made in that aspect.
Right. Hamid, one of the questions, I mean, I'm trying to make sure that we are going in a flow so people see the connectivity. What role vaccines can play in relapses in some people who had relapse cases of COVID? And how do you see the correlation building on your previous discussion?
Now, there are two kinds of relapses in the community. So people first need to understand, what a relapse really is. Now, say if I've got vaccine or if I've recovered from COVID, if the virus try to come in again into my body's entry points, now there is nothing really concrete, at the nose with the closed gates that virus can't enter. Virus will still come in, right? The doors are open. Virus will still come in. It will interact with your mucosa, start multiplying. Your immune system will kick in, try to diffuse the virus. Now, some people, depending on IgA levels in your mucosal membranes, some people might diffuse it very quickly. Some people might take a few days to diffuse it off. Now, if you just go around and start doing nasopharyngeal swab in people will test positive because there is a virus, right? So when people talk about relapse, you might test positive, afterwards, but it doesn't mean you will fall severely ill. You might get a bit of symptoms. Some people might not get symptoms. Some people might fall a little bit of ill, but they will not fall severely ill because your body is aware of the attack before. Your body has produced antibodies before, and if you have been vaccinated, particularly, then you have got army of antibodies already ready in your blood circulation to diffuse the virus out. So there's no way. The previous knowledge of other viruses, the immunology, the infections teach us that this is what's going to happen. Now, what happens with this particular virus with another angle is virus mutates and change. And we look at the flu virus, since we had the Spanish flu, the virus has never left us in the communities. It always comes in winter. The H1N1 mutates, H3N2 mutates, and they keep coming every year and infect the communities. And these viruses, because they don't have their own internal control system to protect their DNA or RNA, if you like, in these RNA viruses, they mutate a lot more faster and uncontrolled with a chance prevalence or survival pressure, if you like, in genetic terms. So in 8 to 9 months, we have already gone 1 year in pandemic. It's the first anniversary now we're talking about. So virus has gone material change in different communities. And if a very changed version of virus comes into you, and if you have plenty of antibodies in your blood, still you might not be protected because if the virus has changed really much. But depending on the vaccination strategy, as to what vaccination strategy have we used, how much polyclonal antibodies your body has produced, because you're not talking about monoclonal antibodies here, it's polyclonal antibodies, and there are many antigenic sites in the virus, and your body is clever to understand quite a few antigen sites and maybe produce a response accordingly. Your T cell response would be there. And interestingly, there has been some studies in some parts of the world, particularly Michigan State, where they had some seroprevalence done with coronaviruses before COVID, because coronaviruses were one of the main common cold causing problem in that state, and lots of elderly people die every year. So they were testing which kind of cold viruses attack in the community. And they found out that there were about 4 viruses which infect 4 coronaviruses which infects the community in the cold season. And the T cell response was quite cross-reactive against type of coronaviruses. So if people, like you were talking about adenovirus pre-existing immunity, if a community had pre-existing immunity against other coronaviruses, they are likely to recognize that virus early in the T cell response before the antibodies kicks in, which would provide a much more protective effect in the community, which is why you see, if you look at around the world, some people did not have a very high mortality The infection rates were very high. People were falling ill. The virus is spread similarly across the world, but they did not fall severely ill. The ICU admissions and mortality rates were lower in some communities, and that explains that logic of T-cell response.
Right, Hamid, is since you were talking about the somebody who gets it and there's going to be still shedding it, we do know that it is also shed through the stools. And one of the questions was that if you do get the vaccinated, can you still be shedding it in your stools? Is it a matter of concern? If you are shedding the antigen, you are protected, but can you still pass it on?
Yeah, lovely question. And there are two aspects to that. The first one is people are worried about saying, what's the point of having all these vaccines if you're still spreading it out, if you have to wear a mask, if you can't meet, if you can't socialize, and what's the point? So to those, that part of the question is, it's just the interim period, because not everybody had been privileged to get the vaccine. The supply is short. By the time majority of people will get vaccine, it's okay to spread it out then, in that case, because everybody is protected. But if you are spreading it out and other community members are not protected, that's a bit like a selfish attitude. You need to look after others. If you were privileged to get the vaccine first, but other people are not, then you should be protecting other people. But once we achieve the herd immunity target, which would be soon in a few months, then we should be okay to not wear protection. We should be okay to mix in communities. It should be all right. So that's one aspect of looking at it. The second aspect is the stool. The studies in the last year has clearly indicated virus shedding in the stools. And one of the many people will think about, how does it end up in the stools? It's a respiratory virus, it's staying in your airways, it's affecting your pneumonia. How does it come up in your stool? The simple answer to that part of question is that, when virus affects your throat, when virus affects your oral cavity, there is a very strong correlation of viral load in the saliva, in your mouth, and the disease severity. So that's saliva, you swallow, it goes down, you eat, you drink, sometimes you even swallow your sputum, and all that virus is dumped in your stomach. So it goes to your tummy, it causes a gut infection. In many gastroenterology registries, we have seen a number of people admitted in hospital and being looked after in gastroenterology clinics with a gut infection. We've seen people with diarrhea, we've seen people with vomiting, and we have seen people with a severe hepatic damage, liver damage. We can really pick it up very high. And that old virus, kind of multiplying in the intestines and infecting the gut, then comes out in the stools eventually. Now, stool shedding was also used as one of the early marker, when we didn't have enough tests in the communities. In some of the European countries, what they were doing is they were looking at the sewerage, they were looking at the sewers, and they were taking samples from the sewers, and they were identifying postcodes where the virus load is coming from. And they were trying to find out where are the hotspots of the virus in the community.
And I just want to add here that we were getting many patients during the first wave specifically, and somebody did ask this question, with the GI symptoms, and a lot of them were testing positive with the typhoid, and they were getting all the results for active typhoid. So it's a possibility that they did contract it through the same route. So maybe you would like to shed light while you're discussing that.
Yes, I think it's a very important point, because often we are so focused with one disease that we don't look at the other comorbidities, particularly in an environment like Pakistan. Typhoid comes in the summer. So when you were talking about last year, there were lots of people coming in with typhoid and enteric fever because of that. Lots of people had dengue outbreak in particularly cities like Karachi. Dengue is also a virus outbreak. So two viruses at the same time affecting person, obviously it will gonna reduce the chances of survival, or will lead to poor prognosis of the disease. Also, now in the winter season, we're not testing people for H1N1, H3 and 2. So there is a lot of people with a combined infection, and H1N1, H3 and 2 takes a couple of 3,000 lives in winter in the UK anyways, every year. That's the norm. We try to provide flu immunization in September, October time until December. So before the severe winter kicks in, we try to protect some vulnerable communities with the flu virus, but still it takes away the lives of many people in this season. So imagine about that lethal virus along with coronavirus, and you got combined infection. So you're absolutely right. So I was mentioning about the postcode prevalence in Europe, where they were looking at the virus shedding in the postcodes, and it was a very good tool to identify the hotspots, because you couldn't do, mass community testing in those days. Now, coming back to the third aspect of this stool shedding is, interestingly, not many people think from that side, but the PCR, the way you pick up the virus from the PCR signal, is not a microbiology assay. And when you're looking at the viral particles, you don't know the viability of those particles. So you might have got stool detection, but all those viruses could be fragments of viruses, could be the dead pieces of viruses. It doesn't mean that virus will infect other people. That's the other aspect of it. So because of the viability in the PCR assay, we detect the quantity of virus. It's a quantitative PCR. If you go for a quantitative assay, you can find out how many particles were there, but you wouldn't know unless you do the microbiology. So you are looking at IFUs, the infection causing units. Or
Right.
So that's another aspect to it. But the conclusion is, it does spread through the gut. It does spread through poor sanitization. So hand hygiene is the best. So people should be careful, whether it's typhoid, whether it's the viral spread through the stools. You should be careful, promote hand hygiene, and make sure in your toilet facilities, in the community, in the public places, you've got hand hygiene facilities available. You make sure you've got soaps and detergents there, and look after that in your household as well. And that's one important way of protecting the spread, not only because of the like the aero spread, but also through the stool spread.
A very typical question which a lot of people have asked is about the immunity. If somebody's immunity is down, somebody is immunocompromised because of, let's say, renal transplant, is already taking medicines to reduce the immunity, or somebody who's above 80, how do you see the safety levels for them? And then a lot of people who might have allergies or are prone to allergies, how do you see the safety of these vaccinations for them?
It's a difficult question to answer, because all the safety trials we had for the vaccines are a short-term trial, and the subjects in the trials are still being monitored for at least a couple of years as per the regulatory pathway, because we were in an emergency situation in a global pandemic. So the vaccines are approved as an emergency authorization. None of the vaccines has been fully approved in the regulatory pathway, if you look at that. So going back to the people with pre-existing conditions, we know that some genetic vaccines would depend quite a lot on a good immune response to stop the vaccine transcription process. So I don't know what the audience is. If you've got medical, kind of colleagues sitting in there, they would understand what I'm talking about. So if you've got the mRNA-based vaccines or the viral vaccines, your mRNA is being transfected into your body's healthy cell. Now your healthy cells start producing spike proteins. Now that process is then identified, recognized by the immune system, and then the immune system diffuses it off. In return, you get the antibodies at the end. Now, what if you are immunocompromised, as you said? What if you have HIV in the past? And what if you don't have a T cell response? Now, what are you going to do? Now, that process, that chain reaction is kicked in. And how would you stop that? So from that point of view, the long-term safety studies are required to make sure that those people can have those kind of vaccines. Also, we need to look at from another point of view that we have got a variety of vaccines. So are there any other vaccines which might be more safer for those individuals? So yes.
So let me characterize, let me give you a specific, because somebody's asked a very specific question. I think that'll help everyone. That if somebody has had a renal transplant and they're already on immunosuppressants, such as delta-cortil and other medicines, without going into detail. So would they be better off with the genetic, or would they be better off with the, I'm just putting it out there, and I think the answer is pretty much clear, but would they be better off with the genetic, or would they be better off with the conventional vaccine?
Yes, if I was trying to explain but if you're looking for a short answer, the answer is go for a non-genetic version of vaccine, go for conventional vaccine, inactivated viral vaccine, or the subunit vaccines. They are a lot more safer for immunocompromised people. Immunocompromised people are people with renal transplant, but also people on specific antibody therapies. Like if somebody has got multiple sclerosis or arthritis and they are having sclerosimab or toxicimab, those kind of medications where you've got specifically T cell targeted. So those people should speak to their immunologists, speak to their consultants, speak to their doctors, and take advice before taking vaccine. Do not just go out and choose the vaccine yourself. Take the expert advice, because we're lucky in Pakistan that we've got 3-4 different varieties, as Dr. Zair was explaining earlier. You can choose, and it's available in private sector. So it's not like in UK, although we are much more advanced country here, but I tell you, we can't choose.
So since we've heard about internationally in Germany and other countries that there have been in clusters and there have been deaths and other issues, so how concerned are you about, let's say, down the road, we are hoping that all those, like Dr. Uzair mentioned, CanSino Bio is one of those, and maybe I'm hoping that Pfizer and Moderna would be available in the coming year or so. So if people do get those, or if people do get those if they are traveling, are there any concerns specifically for a specific age, or any specific concerns?
I'm sorry, I didn't quite understand the question. Are you
So
referring?
I mean, are there any concerns for those patients because of the side effects in large clusters of older population in Europe, specifically with Pfizer and some of the other mRNA vaccines?
Now, again, this goes back to vaccine types, and older subjects are automatically classed as immunocompromised in some aspects. So when the age goes up really very high, 80 plus, then the immune response is very weak. So what normally we do in flu immunization campaign as well, we give them a specific flu vaccine, not the ordinary flu vaccine, which has been adjuvanted to just wake up their immune system a bit. But that vaccine is a little bit hard, because then you are putting a double antigen in there, and the vaccine sometimes will really feel you a little bit ill and sick. But that's just a normal immune response. It just shows that your body is working, is reacting against the vaccine. So lots of elderly people, because of that effect, would react to vaccines slightly differently than the adult people will react. And the genetic vaccines do not require adjuvants, because they force your immune system to react. They have got that built-in ability to manipulate your cellular response, and your body does react very fast. And that's why some elderly people have got that. But also most of elderly people are living with existing conditions. Many would have issues with diabetes, and lots of people might have got other immunocompromised condition. Lots of people might be taking some steroids. Lots of people might be taking some other immunocompromised drugs. People are living in UK with, for example, ulcerative colitis, Crohn's disease. They've got multiple sclerosis. So all those factors need to come in. When we look at, generally we talk about elderly people, but they have got underlying conditions which often explains why they react to certain conditions and certain vaccines. So maybe a more safer approach would be to use a non-genetic version of vaccine if somebody has got a lot of pre-existing condition and is elderly and is likely to react. But again, that decision has to be made individualized, case-to-case basis, and you must consult your doctors, you must consult with your clinician, whosoever you are in care with, speak to the same person who knows your medical history, and then bring this question up. We can't give one answer to everybody in the community. That would be very dangerous. And I would suggest a careful, personalized approach in this matter.
If somebody asked a question, how long does the messenger RNA vaccine, how long would it remain active, and it would continue to produce spike proteins in the body? Is there a way to gauge that?
It's difficult to give again a 100% correct answer, but looking at the phase 1 and phase 2 data, that neutralization happens within 4 to 8 weeks, and that's where your body's immune system completely eradicates the load you have injected in. So you inject a fixed amount of load into your body. The load you inject cannot multiply and grow, which is why all the viral vector vaccines have been silenced. In the past, in 1980s, early 90s, the viral vectors could also multiply in the host, which is why sometimes there were more safety concerns in those times when those viral vectors are being tried for gene therapy. But now we've got 5 more generations of viral vectors going through, a lot more safer generation of viral vectors. They are silenced, they don't multiply in the human host. So you put a fixed dose in and your body neutralizes it likely in 8 weeks kind of cycle. But again, that neutralization depends on how good your immune response is. If you're on immunosuppressants, then that chain reaction might go for longer. And how long it will last? Does it lead to long-term safety issues? Which was what I was trying to clarify in my previous response to the question, saying clinical trials are still running on. The other aspect of clinical trial was that most of those immunocompromised patients were not included in the trial. In many vaccine trials, they were excluded as part of the routine inclusion-exclusion criteria. So people who have got the vaccine now, they're being monitored by the pharmacovigilance studies across the world, the MHRA, the DRAP in Pakistan, the FDA, they all are looking at that, and more data will come in the future. So the real answer is, honest answer is, we don't know yet in those individuals with immunocompromised function, with HIV or organ transplant kind of thing, or with some medications. But in healthy individual, it should be mocked up within 2 months.
Given that there's so many variants now coming in and it has started to increase in speed, we do know that at the end of the year, we had just heard of B117 and then B1351 and P1. So the number of mutations are increasing. So with this, which vaccination or which vaccine would be easily upgraded or be able to, updated in the sense that it would protect us against those variants? And also, would we need more than 2 doses in future?
Very good question. And I think people should understand that in the press, we talk about only 4 or 5 new variants, which has been the reason for problems because they have attained a very different genetic form, and they've been changed quite a lot from the original virus. But people should appreciate that there has been about 16,000 mutations reported in genome database. So it's not only 4 or 5 variations, and that's not surprising. To us, to the medical community, to the scientists, it's not surprising. That's what we have seen with other viruses. That's what we have seen with the flu viruses. Viruses do change, it always change. But a little bit change doesn't matter because you've got polyclonal antibodies, your body still recognizes it. If there are 16 different changes to one particular site, then it's a completely different antigen, so body doesn't recognize it. So from that point of view, it's not worrying. It's not worrying at all. It's not problematic because you can have annual flu vaccination cycle. What you could do is, so immunization is 2 costs. One is the cost of vaccine, and the second one is cost of immunization, like providing it to the community, injecting it out, giving appointments, people coming in, nursing staff involved, all that. So it's 2 costs. So what we might be able to do in future, we currently have a quadrivalent flu vaccine in our public health campaigns. We could have a 5th antigen in there if there was a compatibility in formulation trials. So half of the cost is already covered because you already have an immunization clinic every year. And then the little bit of cost will change because of the vaccine formulation you're adding in another process. So that can be mitigated. We live in a modern world and we are a lot better than what we had in Spanish flu. The second question you asked about the vaccine technologies as to which vaccine formulation would be easy to cook up. In that case, genetic vaccines from industrial point of view are easier because you can pre-program the genetic code and then you can produce copies in cellular system by using genetic recombinant technologies, and then you can produce it. The second part of the question comes into the how long it will take for the vaccine to come out, because making a vaccine in the lab might take a week maximum. In a week, the vaccine is ready. But then what would be the regulatory pathway? Do you need to go through all preclinical screening again, animal trials, phase 1, 2, 3, and then you might want to take again a year. So an example I would give to people is look at the flu vaccine, right? So when the winter season finished, the global surveillance of flu virus is collected from all locations in the world, feedback to WHO, Viral Prevalence Center, and they decide on what strains are likely to come next year, and then they provide that information to vaccine manufacturers. They start manufacturing in March, April. By September, vaccine is ready. From October, we start receiving it in the community, and that's the cycle. It's been regulatory approved. There is a history, and flu vaccine is also a virus which has been produced by two main methodologies. One is a tissue culture, you grow it in a cell line. The second classic approach is in chicken embryos, so you multiply and grow the virus there. And there is a problem of speed. They take still 6 to 8 months to produce in mass quantities and bring it out, which is why they moved on to the cell-based approach, which is a lot more faster in terms of production scale. So there will be different choices. Different companies will go for different strategies and approach to produce vaccines. And having a choice, having a variety is a good thing. I would not discourage. Even a classic vaccine is not very difficult to produce. If the global surveillance centers are giving away the strains required for the next immunization cycle, they can grow those strains in chicken embryos in a classic vaccination style model, produce it on the mass scale, few months vaccine is ready. So I personally think, although genetic method is quicker, smarter, faster, but there is still a need for the conventional vaccine approaches, and we can definitely do it by any method.
Great. One of the questions was that you did mention in your last session that UK has ordered almost, I think, 7 different companies. So if they've ordered that, is there going to be combinations other than only the Sputnik and the viral vector ones that you can combine them? But is there going to be other combinations, and are they safe? And is that going to be the way forward?
I think first, people are wondering why UK, decided to order so many different vaccines. And to understand the strategy, if you go back in early pandemic, say in April time, when people were dying, in United Kingdom, we had about more than 1,000 people dying per day in April. So this was a very peak period. We were in a lot of pressure. The vaccine was a way out, and government don't want to put all the eggs in one basket. So what if they relied too much on one vaccine and that vaccine failed? So they cleverly decided to invest their money into different vaccines. They did not know which vaccine will be proven effective. They did not know which vaccine will come out first. So they invested their money in different vaccines, and not just same vaccines or different companies. They invested in different vaccine technologies. So they invested in the genetic vaccine. They also invested in non-genetic vaccine. So in UK, we only have currently viral vector vaccine and non-viral vector-based genetic vaccine rolled out so far, but there are 2 other vaccines being locally manufactured within the country, which are non-genetic vaccines, and they are due this year. So they will be coming out as well. So the idea was not just because we wanted to combine vaccines, it was the how quickly a country can get out the pandemic and what would be the fail-safe approach. And that's why they ordered so many vaccines. The second advantage of this strategy is that one vaccine production will take time to immunize the whole country. And if you have 7 different vaccines are being manufactured at the same times, then you are likely to get more vaccine outputs and immunize more people across. So the idea was not just to mix and match and because you will be more effective. That's not the main reason. The reason was strategic at that time to get out of the pandemic sooner and succeed in a fail-safe approach kind of thing. But now, because there's a shortage of vaccine, so there are some extra trials looking at what if we mix 2, what's going to happen. So there are 2 issues. One is the safety, but the other one is the efficacy. And in my opinion, if you are exposing your body to a variety of antigenic style in different formulation, you are developing a more polyclonal spectrum of your antibodies. I don't think there is an issue with the efficacy at all. There might be some consideration to check if how the people would react immunogenetically if you mix different type of vaccines.
Okay, Hamid, one of the very sensitive question, and since you are in UK, I read the survey that the maximum number of people who are refusing to be vaccinated are ethnically from Pakistan, or originally from Pakistan. And so there are a lot of issues about the topic, that there are genetic materials that are coming from different animals, and they're not safe. They can react, and they can interact with our DNA, our genetic material, etc., and is it safe? So a lot of issues around that. And also, how do you convince them about the anti-vaxxers that why they should get vaccinated and how safe it is? So on that accord, please.
So the honest answer is that there are two types of people. One, innocent public, which are worried, which are being felt like they've been not treated fairly in the past, and they've got genuine concerns. Then there is another group of people which are pure anti-vaxxers. So we can never convince anti-vax people, and we don't see a point of how we could deal with that. So we can never convince them, in my opinion. What we can do is we can neutralize anti-vaxxers campaign by speaking to the community, the genuine people who are worried, and rather than one approach which medical community had is just every anti-vax propaganda you see, say, oh, it's wrong, it's false, rubbish. We never try to go to the community closer. What do you think? Why you are worried? How does it affect you? And then trying to diffuse situation that way, give them evidence, give them reasons, give them logical reasons to explain. One of the reasons I tell you in United Kingdom, in flu immunization campaign, we had a majority of young children, school-going children, being offered a nasal vaccine. A very effective vaccine, very clever technology, produces mucosal IgA levels, and fantastic because you don't need injections, you don't need nurses, you do it in schools. So any school-going children get that. Now I tell you, majority of our community don't get that vaccine. Why? Because there's a porcine gelatin in it, and public health agencies didn't do nothing to replace that porcine gelatin. Now, people had the choice to get an injectable flu vaccine, which had no animal ingredient, which was acceptable for a lot of Muslim communities. And Muslim communities in the United Kingdom thought we have a choice. So if there was no choice, all right, we can think about porcine gelatin as a source for preventing life. But if you have a choice of a non-porcine gelatin vaccine, which is injectable, go for it. But many public health agencies in different parts of England did not honor that to Muslim communities. And that's where people are annoyed. People know something happened in the past and they're always suspicious with the COVID vaccine. So we need to tell them that COVID vaccine do not have porcine gelatin in it. COVID vaccine do not have those animal products in it. And there is a certification came from British Islamic Muslim Scientists Association, BIMA as well, which has certified the ingredients from the vaccine manufacturers. They did their research, they've investigated every single ingredient, and they've spoken to Muslim scholars in the United Kingdom. And
so Hamid, you're saying that this scientifically, this, at least as far as COVID is concerned, and these vaccines that are available to Pakistan, they're safer, they do not have all those ingredients which could be questionable. And so that issue should be removed from everyone's mind, and it is scientific fact.
What we need to do is holistically, we look at each formulation and we should work with the manufacturer, and we take it as a positive approach. We take all the vaccine ingredients, publish it out in communities, and publish it out in newspapers, open up. Don't keep information. Disclose all the ingredients and tell them, look, these are the ingredients in these different brands, these are the products, and how these are being made. And then the religious scholars should be on board in Pakistan. You work with them, and then they issue their verdicts, and then people will be on board. You can't just say, if I make a statement, people are not going to listen to me.
No, but your statement is a science, and with your background and with your education, I think it means a lot. Because I'm just running out of time and I would like to just end this. And the last question is that most of these vaccinations are not for under 18. Do you think in the future there is going to be vaccinations for children or individuals under 18, or you think the focus is going to be only above 18 and adults and maybe older adults?
There are two reasons for not having a vaccine under 18. One was that in the clinical trial, it was never tested in below 18. So because we don't know how under 18s reacted to the vaccine, then that's why the government decided not to license it to under 18s. So it's not that vaccine is not safe for under 18. It's just
it was just not tested.
Number two, second reason was that when we look at the mortality data, young people did not had they were receptive to the virus, and they were not falling ill, and they were not in immediate danger. So all the focus was on the elderly community. The third aspect is we already had a nasal COVID vaccine being designed in United Kingdom, and that's been starting with phase 1-2 trials now. And once that vaccine goes through the clinical development process, that would be like a flu vaccine, a nasal spray, and it's a live attenuated virus. And that would be easier for the younger children and communities in the schools, and you can have a mass immunization campaign there.
Great. I think, Hamid, I've kind of run out of all questions. We could definitely go on, and I'm sure all the participants would love to hear more, but I should hand over back to the rest of the team and to Dr. Uzair and Sidra. So thank you so much for participating. Back to you, Uzair.
Thank you, Ismail and Hamid, both of you. I think it was a wonderful session and we thoroughly enjoyed. So I would like to share something. We have with us the top man from Chughtai Lab, which is the largest chain in Pakistan. And they have so much in terms of dedication to bring the vaccines to Pakistani communities. These are the public goods and the most cost-effective approach. And I'm so delighted and happy that he is around with us, really endorsing and bringing the vaccine available to Pakistani community. It was very enlightening session, Hamid, and I know from your busy schedule, you always entertain us and you accept our request. So from the Pakistani population, the community, and all of us, we are extremely thankful for your extremely valuable time and saying yes to all our very time sensitive request. So it was a pleasure to be with us. So Zafar, would you like to say something, please?
Yes, thank you for your invitation, and you're most welcome, Dr. Zair.
Thank you. So last word, I think, let me see if Mr. Zafar from the GMS, because he provided on the platform, if he's around, he would like to say something. Zafar, can you unmute your speaker mic, please? I think we have a issue with that. So no, not a problem. So we formally close the session.
Yes,
And
now I can say just thank you to all the participants, especially Dr. Hamid for his active presence, and second time he came just to answer the questions. And I think this is the great knowledge we all people receive from him. And this definitely, this will be a right time because we are just launching vaccines into Pakistan. Thanks to all.
So thank you. I think that we stand close. Thank you to all of you and the valuable speakers. So let's see sometime next with the new issues. Take care and goodbye.
Thank you, Uzair. Thank you, Zafar. Thank you, Hamid, Dr. Hamid. Thank you, all of the participants. Thank you. Bye-bye.
Thank you, Dr. Shumail, for moderating the sections and asking questions.
Pleasure. Pleasure.
Thank you, the organizers and all the audience for coming in. Thank you very much.
Thank you. Bye-bye.